record on this. So I'm trying. So
Recording
I'm
in progress भनेर आयो रे
आयो हजुर
and so I think I'm trying it my मेरो कम्प्युटरमा गरिरहेको छु अब I don't know if it lets me record all of it or not हैन तर I'll try.
ए हस् सर किन मैले लास्ट टाइम एकचोटि हाम्रो नर्मल मिटिङ गर्दाखेरि चाहिँ अलिकति त्यो सेभ हुँदाखेरि एकदमै टाइम लाग्थ्यो अनि
हजुर
त्यही भएर मैले चाहिँ खासै ल्यापटपमा चाहिँ अलि उ नै हुने
अनि I think टुडेको for today's moderator चाहिँ डाक्टर शीतल हो हैन
हजुर
उहाँ जोइन गर्नु भएको छैन है अहिलेसम्म यो अब I can't like there are few
म एकचोटि सुभाष सरलाई सोधेर अहिले कन्फर्म
yeah
गरिहाल्छु
सुभाषलाई नि actually can you just let him know so अब हामी
हस्
I think
sure
I think there are few of us here हैन ल अब के नमस्कार है सबैलाई I think we will wait for next 5-10 minutes and then we'll start नेपालमा at least Dr. Subhash or Dr. Sheetal I will try to reach out and I think I see Kamal I see Rajdai नमस्कार है सबैलाई यहाँ परेश दाइ पनि हुनुहुन्छ
Hello Raju
Thank you for making it.
Yeah, third time's a charm भने हैन तिमीले
हो त नमस्ते सबैजनालाई मेरो त आज म सर्भिसमै थिएँ म त भर्खर एकछिन अगाडि मात्र आइपुगेको यस्तो बिजी थियो अनि ल थ्यांक यू दाइ
Oh, thank you.
I think everyone was anticipating last Korea podcast. This is a great topic, I think, for discussion, right?
Yeah, the great topic, but not a whole lot of literature. Right? It's more physiology based. So I've kind of focused more on physiology. Hopefully it'll work out.
Still, like lots of times, you know, even के गर्न हुँदैन भनेर पनि याद गर्नुपर्ने चिजहरू के
Yeah, I don't know. You're right.
Pretty much, it's like what are the things that don't help or what are the things that can hurt more भन्ने नि याद गर्नुपर्ने चिजहरू pulmonary hypertension it's very like हामी चाहिँ we're very cautious किनकि anytime we have right heart failure or pulmonary hypertension patient भयो भने even to intubate we are pretty much preparing family preparing patient that it might not get.
Yep. That is the right thing to do. See some people on the chat. In the morning, gaउने होता in the meantime.
Yeah. I think it's I see Subhash here.
सबैजनालाई हेलो है
नमस्ते नमस्ते म डाक्टर सुभाष
Hello.
Subhash, do we wait for Dr. Sheetal?
I'm just trying. I just called him, but he seems he's traveling and on the way. I think let's not waste much time and start. And he'll join later. I've dropped him a message. He says he will join later.
Okay, so I think we have 17 participants. We are like 5 minutes out from our scheduled time. Do we start or do we wait for a few more minutes?
No, let's start. I think let's start.
Okay, so now that Dr. Sheetal is not around, I'll try to introduce Paresh Dai from my end, from what I know. You know, Paresh Dai Paresh, Dr. Paresh Giri, good morning everyone. अब नेपालमा भएको साथीहरूलाई good morning. अब यहाँबाट join गरेकोहरूलाई good evening है. अब म चाहिँ नवीन कैनी. I'm part of ANMF collaboration committee. I work with Dr. Subhash, Dr. Raju, and we're trying to coordinate every month critical care forum where we try to discuss and conduct a session that's important for us in ICU, and hopefully this is of academic help for all of us. Today we have Dr. Paresh Giri. Dr. Giri did his MBBS from TUTH teaching hospital, and then did few years in Nepal. I think he did primary care in Doti district, and then came to United States, did his residency and fellowship in California. He did his fellowship in pulmonary and critical care in Loma Linda Hospital in California, and he joined as a faculty there for the past close to 12 years or 11 years now. And he's worked as pulmonary hypertension. His focus is mainly, he's very interested in pulmonary hypertension and has worked as a program director in pulmonary and critical care fellowship, as well as pulmonary hypertension subdivision in pulmonary critical care service in Loma Linda University. He has had lots of publications in pulmonary hypertension and right heart failure, and today we're very glad to have him for the talk of intensive care management of pulmonary hypertension and right heart failure. If anything that I've missed, Dr. Giri, you can take it from here.
Thank you, Naveen. Thank you, Dr. Kaini. Appreciate you, and thank you, America Nepal Medical Foundation (AMNF) for the opportunity. I was namaste to everyone in Nepal. I was born in Birganj. You probably know where that is. I grew up there, and now I'm practicing here in California. So today's objectives are to define pulmonary hypertension and pulmonary arterial hypertension. There have been a few changes in the definitions throughout the years. And then I will discuss, I titled this talk as intensive care management, but I think I'll spend half the time talking about the pathophysiology and then maybe gear management towards that pathophysiology, because as you know, there's not a whole lot of literature and head-to-head comparison in management. So it's mostly physiology based. And so I'll try to focus on that. We'll talk about three major principles: the Ohm's law, which I call the electricity law; Poissier's law, which I'll call the pipe law; and Laplace's law, which I'll call the balloon law. And I'll refer to this in the rest of my talk. Then we'll use three cases. The first case is an idiopathic PAH patient that I encountered in my practice. Actually, all three cases are cases that I've encountered. The second one is someone with heart failure, preserved ejection fraction, which is probably more commonly encountered than idiopathic PAH. And then third one is PAH with sepsis. So let's begin with a case. This is a 29-year-old female. She was diagnosed with idiopathic pulmonary arterial hypertension 5 years ago. She was under my care. Now she comes in with worsening shortness of breath and bilateral lower extremity edema. On examination, you see she's got a respiratory rate of 20, blood pressure is slightly low, heart rate is high, she's on 3 liters oxygen. She's got jugular venous distension, crackles, findings suggestive of right heart failure, epigastric tenderness, and bilateral lower extremity edema. This is her echocardiogram, the parasternal long axis view, showing significantly enlarged right atrium and right ventricle. And you can see on the apical 4 chamber view, there is significantly enlarged right ventricle. It's also hypertrophy. You see the thickened walls there. And the right ventricle is significantly enlarged in the apical 4 view, as well as in the short axis view. And you can see there is a D sign there with, did you lose my screen, or can you see it?
I think we lost I think we lost your screen.
Oh, let me share it again. Something happened here. I don't know what happened. I just got disconnected. Oh, I did that. Where is my share screen?
In the middle.
I don't know why I did that. That's strange. Can you see it now?
Yes.
Okay, great. All right, so here's the short axis view in the extreme right. And you can see that there is a D sign. What happened again?
I think we're losing your screen.
Okay, it says share screening stop because the external display is disconnected. I don't know what that means. I think it's this video that's causing an issue then. Can you see now?
Not yet, no.
Oh, I don't know why it's doing that. I can.
Yeah, we can see it now.
Okay. Yeah, I've got two screens. That shouldn't cause a problem. So there was color droplets showing significant tricuspid regurgitation. And based on, can you see my arrow here? No?
Yes.
Okay, so this is tricuspid regurgitation. This is used to calculate pulmonary artery systolic pressure, which based on this is 90 millimeters of mercury. And tab C shown upper right corner here, which reflects tricuspid annular plane systolic excursion using M mode, shows that it is decreased. Right heart cath was done. That shows that RA pressure is elevated, RV is elevated, pulmonary wedge pressure was normal. The mean pulmonary pressure was 76, as you can see there. Cardiac output is decreased, PVR is very elevated. She is on 3 specific pH therapy, and she's also on a prostacyclin pump as well as a dobutamine pump at home. And you can see on this X-ray, she's got 2 peripherally inserted central lines, one for dobutamine, one for epoprostenol. Lab data shows hyponatremia, acute kidney injury. These units are probably different in Nepal, right? So you probably have to multiply by 80 if you want to convert it to micromoles. Pro-BNP is elevated, lactate is elevated, and mixed venous O2 is decreased. EKG shows evidence of right heart strain with maybe our right frontal branch block. CT scan shows significantly enlarged right ventricle, right ventricular hypertrophy, enlarged pulmonary artery. So if you look at this case, she's got severe pulmonary arterial hypertension based on her hemodynamics, severe right heart failure based on her echocardiographic and hemodynamics, multiple poor prognostic indicators for pH, failure of outpatient diuresis and inotrope therapy. And she's now admitted for IV diuresis and workup of what's causing her exacerbation. So this brings us to definitions. Pulmonary hypertension is defined as mean PA pressure more than 20. It was 25 up until a short while ago. Pulmonary arterial hypertension has 2 additional hemodynamic parameters. It includes pulmonary artery wedge pressure less than 15, equal to 15, and pulmonary vascular resistance. This has changed very recently, as of a few months ago, October of last year, to 2 Wood units. And so now the classification of pulmonary hypertension is defined as such on this table. pH is more than 20, and precapillary pH is defined as mean PA pressure more than 20, wedge less than 15, and PVR more than 2, the definition that I wrote down on the previous slide. Isolated post-capillary pH is one that has got a wedge of more than 15, but a PVR less than 2. And combined pre and post capillary pH has a wedge of more than 15, but a PVR that's high as well, more than 2. Unclassified pH in the bottom is got mean PA pressure more than 20, but PVR and wedge are both less than the upper cutoff value. So this is something new that they have introduced this few months ago. And exercise pH is something that was there before, got taken out, and now it's back. And this time, instead of defining by exercise pH by a particular pulmonary artery number, the data suggests that using slope data from mean PA pressure to cardiac output slope increase by more than 3 millimeters of mercury per liter per minute is suggestive of exercise pH. Similarly, exercise post-capillary pH can be assessed by using pulmonary artery wedge pressure to the cardiac output slope, increase from rest to peak exercise of more than 2. So those are new definition parameters that are being discussed. So we will talk about a little bit about pathophysiology using these 3 principles right now. I'll call this the electricity, the pipe, and the balloon law. And then we'll focus on these 3 cases. I'll focus heavily on the first one. So the first principle number 1 is Ohm's law. And Ohm's law equates voltage to a product of current and resistance in electricity physics. Now, if we substitute the voltage for a change in pressure across the pulmonary system, which based on the cartoon to the right is the mean PA pressure is the driving pressure, and then the LA pressure is the ending pressure. So mean PA pressure minus the LA pressure divided by the current, which is replaced as cardiac output, will give you the resistance based on this formula here. So the normal values, if you plug in, will give you a resistance of about 1.2 units. And if you want to convert that to dynes, you multiply that by 80. So the PVR equals the transpulmonary gradient, this number, mean PA pressure minus LA pressure, divided by cardiac output. In systemic vascular side, again, the starting pressure is the pressure in the aorta, the mean arterial pressure. And the ending pressure is in the RA, so the right atrial pressure. Divide that by cardiac output, and you'll get a resistance of around 13 Wood units. If you multiply that by 80, it comes to around 1,000 dynes. So the right ventricle is designed to pump to a pulmonary circulation with low resistance, whereas the left ventricle is designed and to pump to systemic circulation, which has got a high resistance. So if you increase the resistance to the right ventricle, as shown here by increasing the pressure on the x-axis and stroke volume on the y-axis, the right ventricle stroke volume drops precipitously, whereas the left ventricle takes a little while for it to drop. So you can consider the right ventricle to be kind of a ballerina, tiptoeing, dancing. Left ventricle is more of a muscular bodybuilder. When the right ventricular afterload is increased, it can't handle it, it fails. Sometimes the left ventricle fails as well, but it is more resilient, let's say. So here's a question to highlight the importance of the right ventricle and right ventricle failure in pH. So which of the following parameters does not, it's a negative question, does not have a good prognostic value in pulmonary hypertension? So pulmonary artery pressure, RA pressure, cardiac output, pericardial effusion, and positive vasoreactivity. So the answer is pulmonary artery pressure, which is counterintuitive because you are managing pulmonary hypertension and the pulmonary artery pressure is not prognostic. And I'll explain that in the next slide. RA pressure, cardiac output, pericardial effusion, and vasoreactivity all have significant prognostic indications and have been included in risk scoring algorithms like the REVEAL score and ESC, ERS guidelines, etc. So the reason pulmonary artery pressure is not prognostic is partly because of this reason. If you have 2 patients, A and B, who have similar pulmonary artery pressure, but if you look at the person B, his cardiac output or her cardiac output is much lower than the person A. because person's B, right ventricle, has failed significantly and is more advanced than person A. So pulmonary artery pressure is not truly a measure of how they're doing, it's more the right ventricle. And so that's why recognizing RV failure is important in pulmonary hypertension. Now, number 2 principle of determinants of pulmonary vascular resistance is called the Poissier's law, and it equates the coefficient of viscosity, eta, to the length of the tube divided by the radius. If you are pushing fluid through a pipe or non-collapsible tube, if the fluid is thick, more viscous, then you'll encounter more resistance. If the tube is longer, then you'll encounter more resistance. But by far the most important relationship between resistance is with the radius to the 4th power. So even small changes in radius will cause significant changes in the resistance of the flow. This is important because in pulmonary vasculature, in pulmonary hypertension, due to various susceptibility and associated conditions, you tend to get a vasculopathy that involves all 3 layers of the pulmonary vasculature and ends up in really narrowing these pulmonary arteries. In panel A, you can see a histology slide with normal pulmonary artery in the middle with some RBCs there in the middle. Panel B shows pulmonary hypertension with a vasculopathy involving all 3 layers and obliteration of the vascular lumen. So if you use Poissier's law here, because the radius has decreased significantly from there to here, you're going to increase the resistance and therefore increase afterload, and you know the right ventricle can't handle that afterload. So you end up with what we call RV failure. So this is a recreational vehicle. See them traveling the streets, the highways here. Sometimes you get RV failure. So recognizing RV failure is critical. And we have to understand that the right ventricle is different from the left ventricle. In many ways, these are the 5 ways that I'll explain to you now. So first of all, embryologically, right ventricle is originating from the anterior heart field, whereas the rest of the heart is from the primary heart field. So there is some embryological difference. Secondly, anatomy of the RV is different. RV has 2 layers of muscles, superficial and deep, whereas the left ventricle has 3 layers of muscles. Because of that, the contraction and the systolic mechanism is different. The LV has more like of a ringing action, whereas the RV has more of a bellows action. And the apex to base contraction contributes around 75% of the activity, whereas the septum contributes about 20% of the systolic function. The other 2 motions do not contribute as much. So as you know, I showed this graph already on the left side. RV handles increases in afterload very poorly, whereas the left ventricle handles it better. However, the RV does handle preload increases much better, as the stroke work per gram on the y-axis is much lesser for a similar increase in the atrial pressure on the x-axis. RV perfusion is different. In the graph on the left side, you can see as the systolic pressure increases on the x-axis, the mean right coronary artery flow decreases. And on the graph to the right coronary artery, which is the 3rd graph on the bottom, shows that it normally has flow both in systole and diastole. And the red tracing shows what happens in RV failure is that the flow is severely decreased in systole and also decreased in diastole, but very severe in systole. Therefore, perfusion decreases. Now, the 3rd important law, the balloon law, which I call the Laplace's law, in this picture, if you look at the balloon there, it is filled with air, it's tied up in a knot. The pressure inside of the balloon, according to Pascal's principle, should be equal everywhere. However, the tip of the balloon here has very little wall tension compared to this wall and that wall. And this is principally due to the difference in the radius. And so Laplace's law equates the wall tension to the pressure inside as well as the radius. The right ventricle, the wall tension is directly proportional to the amount of oxygen being consumed by the right ventricular muscles. Now, if you compound that with decrease in RV coronary flow, like I showed in the last slide, now you have a vicious cycle where the wall tension is high, increasing oxygen consumption, but that also leads to decreased perfusion, which further exacerbates the problem and is a recipe for disaster. So we have increased wall tension in this right ventricle. I showed you the long axis and short axis views, and this wall is very large. The septum is not moving as it should, and it's not contributing the systolic function as it should. And there is increased VO2 demand, but there is not enough supply, and that leads to RV failure. So if I summarize RV failure and this vicious cycle, you start off with a high pulmonary vascular resistance. Initially, there is adaptation. Your RV becomes thicker and hypertrophied, but ultimately there is maladaptation. There's loss of RV-PA coupling. RV gets bigger and bigger. Increased RV wall stress will lead to decreased coronary perfusion, will lead to RV ischemia, and therefore will lead to diastolic and decreased perfusion, and then compensatory tachycardia and initially decreased cardiac output. The ventricular interdependence on this side will cause decreased left ventricular end diastolic volume, and that will decrease RV preload and therefore cardiac output. To the right, you can see the effects of high RV failure and RA pressure, RV volume overload, TR, high right-sided pressure resulting in opening of maybe PFO or right to left shunt, and features of edema and organ congestion. So a little historical perspective, William Harvey said, the RV is made just for the sake of transmitting blood, and kind of poo-pooed the function of the RV. Initially, there were open chest dog models that got rid of the RV but preserved circulation. However, as people studied more, they found that if there is heart-lung interaction in closed chest models, RV dysfunction becomes significant. And as more data poured in about importance of RV and survival in various conditions, people realized that RV is really important. In 2006, the National Heart and Lung and Blood Institute identified RV as physiology as a priority in cardiovascular research. So hence the title of my talk, Forgotten No More. There are many mechanisms of RV dysfunction in the ICU, and we can go clockwise from the bottom, 6 o'clock. Hypoxic pulmonary vasoconstriction will cause, again, narrowing of the pulmonary arteries, and therefore, using Poissier's law, increase in resistance. Ischemia, arrhythmias will decrease your diastolic filling time, and that can hamper your cardiac output. Mechanical ventilation with increasing peak and plateau pressures, thromboemboli, other microthrombi. By far, LV dysfunction is the most common cause or mechanism of RV dysfunction. Sepsis and endotoxinemia, other idiopathic PAH causes, and capillary leak, etc., all can cause RV dysfunction. The causes include, obviously, idiopathic PAH. By far, the most common cause is left heart disease and all the other factors associated with left heart disease. PH due to hypoxia, again, we talked about these conditions earlier. Group 3, pulmonary hypertension. Group 4, pulmonary hypertension includes thromboembolic disease. Mechanical ventilation can cause increase in pulmonary pressure. And causes of failure include, obviously, PH, that's advanced, but other causes include intracardiac shunt and big valvular abnormalities. And then in the ICU, sepsis and myocarditis, RV infarction, and pericardial disease contribute to RV failure. So now that we've discussed these 3 principles, let's use these 3 cases to illustrate some management principles. And I'll preface that by saying that we don't have any big, large randomized controlled trials showing and comparing one versus the other. It's more physiology based. There is no head-to-head comparisons. And if you look at kind of summary of RV failure management, if you identify a treatable cause, let's say pulmonary embolism, RV infarct, if you have something that you can fix, try to fix it, and therefore treat that and then manage RV function. However, many times we truly don't know what's causing or precipitating the RV failure, and therefore we would assess for preload, afterload, and contractility, and kind of manage these things appropriately. Preload, RV dysfunction, etc. Afterload, correct for factors that cause increase in PVR. Treat pulmonary, use pulmonary vasodilators and dilate these blood vessels, as we talked about. Maximize myocardial function, treat sepsis. And if all of that fails, then consider extracorporeal life support with ECMO and then lung transplantation. If you are looking for an article, and this is a shout out to one of our own, Dr. Ariel Shambhu did his medical school at Teaching Hospital, and he's now practicing, and he's written this article in 2020. It's a very nice summary of how to manage critically ill patients in the ICU, and I would point you to that for reference. Worst prognosis with RV failure, and all these conditions have been elucidated. ICU admissions, left heart failure, COPD, ARDS, and sepsis. This shows that there is mortality as high as 60% if you have RV failure and you're in the ICU, especially if you're using any sort of catecholamines or vasopressors. This shows that the graph in the bottom shows people that have got existing LV failure with a low EF and RV failure and high pulmonary artery pressure, and their graph is significantly lower survival than other entities. In COPD, we know there are many measures, but one of the measures is RV and diastolic diameter. In MRI, which suggests more RV failure. It's got significant survival of correlation. ARDS, we get significant RV dysfunction, sometimes up to a fourth of our patients. And when it is present, it portends more poor prognosis. The etiology is multifactorial, sometimes clots, alveolar damage, remodeling, and then our ventilatory strategies. One could consider lung protective strategies, or as an RV protective strategy. If you keep the plateau pressures less than 30, you're actually helping the right ventricle. And then controlled hypercapnia, which we kind of use in ARDS strategy ventilation. The less hypercapnia you have, the better it is, because hypercapnia causes increase in pulmonary artery pressure by narrowing. So sepsis as well, RV dysfunction is seen as high as 40%. We know those people with sepsis that have got RV dysfunction have a higher CVPs, they're not fluid responsive, and they have higher mortality. So treatment of RV essentially involves this cycle here, and kind of this is a good summary in this graph here. Number one, try to identify the precipitating factors. Sometimes it's arrhythmias, and I've had to kind of even shock some of my patients that have got severe PH that are in persistent AFib flutter. And there is data to suggest that if you have significant compromise hemodynamic, you shock them out of it, you tend to get better cardiac outputs. If you can identify sepsis and treat it in time, that'll help anemia, thrombosis. And those are all precipitating factors that you could potentially address. After that, you want to optimize the preload, afterload, and contractility, like you do the same thing for the left side. So optimizing preload, it's easier said than done, right? Atrial pressure is the same to the failing RV, what the left atrial pressure is, or left ventricular and diastolic pressure is to the failing LV. So if you optimize the right atrial function, you probably get a better position in your cardiac function curve, your Starling curve. However, it's a fine line, and if you lower your RA pressure too much, sometimes you cannot, but if you do, you might cause hypovolemia as well. So you really have to walk a fine line assessing the patient. And assessing volume status in a normal person is hard enough. Imagine assessing volume status in somebody who already has elevated right-sided pressure. So your IVC is going to be big. You might have B lines from other concomitant parenchymal problems. Connective tissue disease is quite common cause of PH. So that can give you ultrasound B lines on your ultrasound bedside ultrasonography. LV diastolic dysfunction is common. It's actually the most common cause of heart failure admission now in the United States, at least for the past 10 years now, more than systolic dysfunction. Renal dysfunction is common in this patient. So, and volume resuscitation is very tricky. It might cause further hypotension. And we were talking about the do's and don'ts of pulmonary hypertension before we started the talk. And I think this is one of them. So RV preload optimization, I'm talking about reverse Bernheim effect. So Bernheim effect was described in aortic stenosis, where severe LV dilation moves the LV septum into the right ventricle, thereby decreasing the right ventricle end diastolic volume and thus decreasing cardiac output. But here we're talking about the reverse effect, where due to progressive structural changes in the right ventricle due to persistent increase in right ventricular afterload, the septum now moves to the left ventricle, decreases the left ventricular end diastolic volume, and decrease cardiac output and therefore drop in blood pressure. So in that situation, if you give more blood, like say a liter of blood on the right side, you might tend to push that septum closer to the left ventricle and therefore further exacerbate this phenomenon and actually cause decrease in blood pressure. So it's trickier in these patients. So once you've done that, now you want to focus your attention to the afterload. And you can do a couple of things. You can start off with PAH therapy. Now we have multiple pathways, and we've got 14 FDA or Food and Drug Administered approved medications that are of different classification. There are many more in the pipeline coming up, but these are what are available in the United States at this time. And these are commonly used in patients with PH in the ICU. Inhaled nitric oxide obviously acts by the nitric oxide pathway. It relaxes vascular smooth muscle, and therefore using Poissier's or the pipe law, as I mentioned, will increase the radius and therefore drop the resistance. And if you drop the resistance, your heart becomes more favorable and the size of the right ventricle gets better. And therefore you use as Laplace's law, the balloon law, to improve your supply demand in the right ventricle wall. And your cardiac output therefore improves. So these medications, inhaled nitric prostacyclins, which also relaxes vascular smooth muscle, and then these are endothelin PD5 inhibitors that also inhibit the vasoconstrictive effects. Essentially, all of these will decrease pulmonary vascular resistance. Prostacyclins, if you give intravenously, sometimes can worsen ventilation perfusion mismatch, and if you give inhaled, it might, like nitric oxide, improve the VQ mismatch and therefore obliterate the hypoxemia-induced pulmonary hypertension. Again, it is kind of a very patient-based and provider-based and physiology-based. And if you need to titrate the therapies that you're given based on the patient that you have. An important difference between pulmonary and systemic vascular resistance is that pulmonary system is more compliant. So the same cardiac output goes through the heart, through the lungs, and then comes out to the whole system. However, the mean pulmonary artery pressure is 12, whereas the mean arterial pressure is around 70. So the difference being that the pulmonary vascular resistance is low, and that's why the mean field pressure is low. That being said, there is also one important difference between where the drop in the resistance occurs. So in red is shown here where the systemic vascular drop occurs, and it occurs mostly in the arterioles of this size, 20 micrometers. Whereas the pulmonary vascular systemic drop in resistance occurs more distally in the capillaries. So there are less muscles in the capillaries and more muscles in the arterioles. So if you are using systemic vasodilators, they will decrease your systemic vascular resistance more abruptly and more quickly than pulmonary vasodilators. So the nitroglycerins and the nicardipine drips that you use will drop your systemic pressure pretty quickly. But the pulmonary vasodilators will not drop your pulmonary pressure right away because there is less muscle to work with. Maybe in pulmonary arterial hypertension, when the muscles are hypertrophied, you may have a little bit more bang for your buck. But important is to do no harm, right? You give these pulmonary vasodilators, you increase blood flow going from the right side to the left side. If the left side is unable to handle it due to systolic, diastolic heart failure, mitral valvulopathy, stiff pericardium, whatever the reason, you will end up with pulmonary edema, hemoptysis, and this has happened to patients. Let me see if this plays. It should. Oh, well, it didn't. Okay, so I mean, that was an angiogram showing left-sided obliteration of the left pulmonary artery, and this is one of my partners who took out this really serpentine clot out, and then I'm sorry it's not playing. This angiogram, very nice. This side was obliterated, and after taking that out, now you get perfusion on the left side as well. So the reason I put that in is that you can decrease afterload by relieving mechanical obstruction. That's the second point here. So if you relieve mechanical obstruction, you increase the effective diameter, decrease the resistance, and improve mechanics of the hemodynamics based on these three principles. Another way you can decrease afterload is by lung transplantation. And our patient that I presented earlier, she underwent lung transplantation, case 1. You can see her pre-transplant echocardiogram here and look at her post-transplant echocardiogram. So right ventricle has already in 6 months' time diminished in hypertrophy. The size has gone down, the wall has become smaller. And look at the size of the RA. It's a fraction of what it was before. So there's significant reverse RV remodeling, and there was obviously no heart transplantation required, only lung transplantation. So the RV does remodel if you decrease RV afterload. If you look at her chest x-ray before, she had these 2 PICC catheters with dobutamine and prostacyclins running as outpatient. After transplantation, now she's got new surgical clips, but look at the size of her heart, already got significantly smaller. The last point here is that afterload, there is kind of a U-shaped or parabolic relationship between pulmonary vascular resistance and lung volume. At higher lung volume towards total lung capacity, the pulmonary vascular resistance is high due to squeezing of these alveolar vessels that are embedded right here in between the alveoli. They squeeze these vessels. They decrease the diameter, decrease the radius, and therefore increase the resistance based on Poissier's law, again, the pipe law. At low lung volumes towards residual volume, the PVR is high again. This time it's due to squeezing of the extra alveolar vessels. And this causes a decrease in the radius, again, Poissier's law application. PVR is lowest at functional residual capacity. So hypoxia and hypercarbia both tend to increase pulmonary vascular resistance. So when you're ventilating your patients, trying to avoid hypoxemia, hypercapnia, keeping the PEEP and pressures controlled and avoiding acidosis help with minimizing pulmonary vascular resistance. However, it's easier said than done, these things. And I think the important thing is to avoid intubating these people. Once you intubate them, you increase the pulmonary vascular resistance regardless. You change the RV afterload, and the medications that you're required during intubation, sedatives, and are very, cause a lot of hemodynamic issues and cause hemodynamic collapse. We tend to keep these patients on high flow nasal cannulas and early goals of care discussion. And we know these patients go into cardiac arrest, they've got a very poor chance of survival. But in case you have to intubate them, which we have done in the past, you tend to use etomidate more because it has got minimal to none cardiovascular effects. So it's kind of the choice of drug. Tend to avoid propofol. Sometimes ketamine is used, but be careful with the tachycardic response because that will diminish your diastolic filling. And if they need to go to surgery and anesthesia, none of the medications truly are spare pulmonary vascular resistance. All of them cause decrease in RV contractility, and pulmonary vascular resistance is increased. So pick your poison here. But these cases are very kind of scary, even for anesthesiologists that have cardiovascular anesthesiologists in our hospital. Another important thing to keep in mind is this reflex. It's a stretch receptor. Once you intubate them, increases parasympathetic drive, decreases the sympathetic drive, causing bradycardia, vasodilation, and PEA arrest. And obviously this has happened to patients, and I usually have some kind of inotrope or vasopressor ready, and if not running, ready at the bedside. So after we've discussed optimizing RV afterload, we focus our attention to kind of contractility agents. We know PAH patients have got low systolic blood pressure, partly because they've got right heart failure, low cardiac output, partly because the PAH medications also cause a decrease in systemic vascular resistance and therefore cause hypotension. And we know mortality is higher if you have these following conditions listed. And graphically, if you look at this graph, there are these 6 graphs, and the black dots are people that died. And if you look at the people that died, the non-survivors, they had a lower MAP, they had a lower systolic pressure, they had a higher CRP, they had a lower sodium, higher creatinine, and a higher BNP. So it's very important blood pressure, although patients have a low blood pressure, we really focus to that. There may be other issues that are involved in hypotension in patients with pulmonary arterial hypertension, commonly catheter and pump malfunction. And these medications are really error prone. So wrong concentration of drugs, just by a fraction of one number, will give you manifold change in your drug therapy. Wrong pump setting, wrong label, pump function. And commonly, nurses or staff tend to flush a catheter when it's blocked, which is kind of a big no-no in patients with pulmonary arterial hypertension, because that flushing of that little push and bolus of these medications can cause significant hypotension, tachycardia, and even cardiac arrest. So if you have an obvious cause of hypovolemia, say somebody comes in with sepsis, yeah, you replace IV fluids. If you don't, then be cautious, because we mentioned about the reverse Bernheim effect and how that can lower LV and diastolic volume. Targeting lactates to lower it, and targeting SaBO2 to increase it is a good target. Watching the heart rate resting is a powerful clinical tool, and titrate vasopressors and inotropes as needed. I usually start dobutamine or milrinone if the patient's normotensive, and I start norepinephrine if they're hypotensive. Here is a graph, kind of nice summary of what different vasopressors and inotropes do to your various parameters listed up here. I like norepinephrine. It increases the cardiac index. It does increase PVR a little bit, but it does cause increase in SVR, so it helps in terms of people that are vasodilated. And it causes a little tachycardia. Sometimes it causes lactic acidosis. Epinephrine, more than norepinephrine, causes lactic acidosis. Phenylephrine, I tend to avoid in these patients because, and that's something that you want to avoid, because it does increase PVR a whole lot, and it doesn't increase your cardiac index that much. So I tend not to, although it doesn't affect heart rate as much, I tend not to use this just because of the pulmonary vascular resistance and decrease in cardiac index because of increase in afterload. Vasopressin is a really good drug, and it's a common adjunct I use quite often. It does not affect PVR. That's a really important value. It does increase SVR, and these patients are commonly vasodilated, and I tend to add that quite often. And in addition, it helps you a little bit diuresis for what it's worth. Dobutamine and dopamine, again, are quite commonly used, as I mentioned. Dobutamine and dobutamine both will increase your cardiac index. Dobutamine actually decreases your SVR, so it might cause hypotension. You got to be careful of that. And epinephrine will increase your cardiac index and your systemic vascular resistance significantly. However, it does increase tachycardia a whole lot. Actually, all of these, dopamine and dobutamine, cause significant tachycardia. So you really have to weigh the pros and cons on the patient that's in front of you and see what happens with these medications. More for trial and error, I guess. Milrinone is commonly used. It is an inodilator, phosphodiesterase inhibitor. It increases your cardiac index, and it drops your PVR and SVR. So sometimes, your systolic pressure might drop significantly with milrinone, necessitating the addition of some kind of vasopressor. I commonly use vasopressin, if not norepinephrine. Tachycardia is not well tolerated in these situations with severe RV failure. So fib and flutter, both atrial fib and flutter, are detrimental. You lose the atrial kick. So you try to maximize, and I mentioned earlier, sometimes I've had to shock these patients out of it if medical therapy does not work. So once you've done your preload, afterload, and contractility, and you still have a patient that's circling the drain, you might want to consider advanced therapy and mechanical support. Now, not many of these are available everywhere, so I don't really emphasize RV, assist device, impellers, ECMOs, sometimes membrane oxygenator, pump layers. We do septostomies in patients that are almost either listed for transplant or for palliative purposes, pot shunt, embolectomy, as I showed you earlier, and finally lung transplantation will certainly decrease your pulmonary vascular resistance once you replace the bad lungs with normal lungs. So going back to case 1, she was admitted, started on IV diuresis, got to butamine. I added nitric oxide. Her lactate improved, her SCVO2 improved. She was sent to UC San Diego, which is around 45 miles, around 60 to 100 kilometers from here. And she ultimately, in a couple of weeks there, she got a lung transplantation, and you saw what happened to her echocardiogram and X-ray 6 months after lung transplantation. So that's about group 1. I've got a few more slides. How are we doing with time? Okay. Couple more slides. Is it okay to go?
Yes, yes, sir.
Okay. So a 75-year-old female with end-stage renal disease, hypertension, bioprosthetic aortic valve repair. She is in the process of getting evaluated for renal transplantation. Her echocardiogram shows 60 pulmonary artery pressure, mild to moderate RV dilation, hypokinesis, severe LA enlargement, diastolic dysfunction grade 2, high cardiac output, and LV ejection fraction of 80%. So she got a right heart cath, and her RA pressure was 14, elevated, RV pressure was elevated, PA systolic pressure was elevated, mean was around 30. The wedge was, A wave was 27, V was 19, and mean was 22. However, end expiratory, which I always report when I do my right heart caths, was much more higher than the mean, computer-generated mean, and I use this number for my calculations. Cardiac output was pretty decent. PVR was slightly elevated. The transpulmonary gradient, which is a mean minus wedge, was normal, and diastolic pulmonary gradient was actually not even elevated. It was a negative number. There is some controversy about using that transpulmonary gradient and diastolic pulmonary gradient in your left heart disease evaluation. I followed Robert Naya for a long time. I like his physiological work. I tend to use that in my practice. So gradient of more than 15, transpulmonary gradient, and diastolic of more than 7 suggests that there may be a component of precapillary disease, and I might be more aggressive with pH therapy. The principle is that if LA pressure goes up, your pulmonary artery diastolic pressure will have to go up in order for the blood to flow from left to right. But if your pulmonary artery pressure diastolic goes up out of proportion to the increase in wedge by more than 7, then something is going on in the lungs. And so in simply, I say that if it's out of proportion, quote unquote, then I might consider, and there is an etiology to explain why you're out of proportion. Say somebody has got connective tissue disease or a history of methamphetamine abuse, then I would consider treating that precapillary disease more aggressively with pH therapy. In this study, clinical characteristics of pulmonary hypertension patients with heart failure and preserved ejection fraction were noted, and receiver operating curves formulated. And this receiver operating curve gives you almost 0.97%. And these are the factors that we use to construct this receiver operating curve. So essentially, if you're older, female, you're obese, you've got a history of this metabolic syndrome, chronic kidney disease, you're on diuretic therapy, beta blockers, you've got left LV thickness and LA enlargement, but absent RA enlargement. If you meet all of these criteria, 97% of the time, you have heart failure, left preserved ejection fraction. You're done. And so I use this to teach my fellows quite a bit. Pay attention to the patient in front of you, and many times you can use the clinical features to distinguish what kind of pH you have. And as I showed earlier, if you have left heart failure and a right heart failure with a decreased EF and pulmonary hypertension, you're not going to do well. And lastly, just 2 more slides now. Case 3, a 45-year-old female, history of PAH, due to methamphetamine abuse, chronic right heart failure, unsildenafil. She presented with severe lower extremity cellulitis, and there was concern for necrotizing fasciitis. She was taken to the OR for debridement. She got that done. In the post-op unit, she was found to be hypotensive. So the anesthesiologist started on debridement, nitric oxide, Milanon, Levophed, norepinephrine, and vasopressin, all of them. So then they were calling me frantically, say, okay, what do I do now? I know the pulmonary artery catheter is kind of gone out of practice, but I'm biased, and I tend to put these in all patients, my ICU patients at least, that have got undifferentiated shock or severe right heart failure that I need to manage more closely. So I did put the PA catheter in her. And these are the hemodynamics that I found. RA pressure was 23, PA pressure mean was 56, wedge was 15, but cardiac output was 9.4 liters, and the SVR was 500. So I stopped everything, stopped all the other medications except norepinephrine, and slowly was able to wean her off of that and got her on our merry way. So in summary, the last 2 slides, Ohm's law talks about electricity and how we can use that to calculate vascular resistance. Poissier's law, or the pipe law, talks about how resistance and viscosity and length of the tube is related to resistance. And Laplace's law, or the balloon law, as I call it, is relation to describes the relationship between the wall tension and the pressure and the radius of a chamber. So these all are applicable to RV failure. RV is different in embryology, anatomy, how it adapts to afterload and preload, the mechanism of its systolic function, and its blood supply and perfusion. All of these are important to understand before we go ahead and start treating our patients. And a treatment is summarized here. You treat the precipitating factors as best as you can. Optimize your preload, it's more tricky in these patients. Reduce afterload, many mechanisms to do that. Improve contractility with medications and mechanical devices. And then I wish you luck, because these patients are really hard to treat and manage. And many times they need to be transferred to an expert center that has got lung transplant and other ECMO capabilities. So that is it. I'm sorry I went over a few minutes. I'll be happy to take any questions. Let me see if there's anything. Oh, it's this one in the chat here. Oh, Shambhu, I quoted your paper, man. I like that paper. Came out a couple of years ago. Good work, strong work.
Thank you, Parsley. Great talk. Great talk. I think this is very helpful. I don't know, folks in Nepal, what the situation is, but certainly pH is a tough condition to manage, and we struggle with it all the time. But this should be very helpful for everyone.
Yeah, and I'm happy to make this available. If you need it in some format, I can send it to you, Naveen, and you can probably share it with anybody who needs it.
Thank you, Paris. It was a great talk. So far on the chat box, I don't see any questions. Now I think it's an open session. If you have any questions, please feel free to ask. Paris is here. I think Shambhu, you can add if there is anything to add. We've already had a great talk here.
Yes, yeah, so, Shambhu, do you have transplant in your facility? Where you are?
Yeah, Paris, I'm actually, I direct the
You direct the transplant there, right?
Program.
Yes. Wonderful.
Yeah. So we did 42 transplants last year.
Oh my God.
3 of which were heart and lung, and they were for severe PAH that we didn't feel like the heart was gonna recover.
Right.
One of them ended up having Emery-Dreifuss syndrome, which actually muscular dystrophy, which we discovered after the fact. The other was a scleroderma lady with really bad, RV, and she got lucky and got a heart along with the lungs. And then we tried to list someone for a heart and lung. Her FAC was like 10, and her RVEF was like just around 10, and I kept arguing with my other colleagues that we should probably list her for heart and lung, and eventually we thought she wouldn't get a new organ, so she got transplanted for lungs only. she ended up on VA ECMO, and whether related to that and hyperperfusion of the allograft, she, had a real hard time and ended up like staying in the hospital for 6 months before she finally got discharged. So no, we've had quite some experiences this past year transplanting these folks.
Wow,
but
you're a busy man.
I think
Wow.
what you said is right. Most of the folks who've got even severe PAs, the RV does tend to recover, and that's been our experience also.
Excellent. So you have ECMO there as well too?
Yeah, we have ECMO, and we do just the broad array of ALD. I do mostly transplant and sarcoidosis, but seeing more and more PH, especially in the pre-transplant setting.
Yeah, no kidding. Wow, wonderful. Yeah, congratulations. That's a great practice.
Thank you.
Very challenging group of patients, and I'm sure you're doing really well. Congratulations.
Yeah, thank you, Dave.
So Paristai, and from our, perspective in the ICU, medical ICU that we are in, most of the times when we have patients with RV failure or a PAH patient or RV failure, we always are kind of very hesitant to manage this patient in terms of intubation, try to avoid it as much as possible. We try to avoid it as much as possible. If we have to intubate, we always have all the things ready in terms of pressors, in terms of central line, so that if we run into any situations with bad shock, we're trying to manage that. But again, even then, we always kind of have hesitancy to do it, and always have patient or the family be prepared for any bad consequence that can happen. And most of the times we hardly go for PA catheter, except for this pulmonary artery hypertension or right heart failure cases. These are the ones that we otherwise haven't, like, in probably several patients in a year, like every 2 to 3 months we place one PA catheter, not a lot, but that's how we do the practice. In terms of PAH medications in ICU, we have inhaled nitric oxide or Flolan, but other than that, we have to do some oral pills and pretty much try to transfer these patients when they are bad, and then transferring them after they are on vent is really difficult, unless we have some other travel capacity, it's hard. So.
Well, I agree with all the points you mentioned. I think these patients are very tough to manage. They decompensate pretty quickly, and you need to have goals of care discussion early. And then you need somebody like Shambhu to manage. Once they get bad, you need somebody. And if you don't have that capabilities, trying to find a higher level of center to send to is difficult right now. And so in Nepal, I can understand the struggles there. You have limited resources, medications, and we don't have any lung transplant in Nepal, do we, Shambhu?
I think we have few audience from Nepal. Anyone?
No, we don't have lung transplant. We have kidney regularly, and now we started liver, but that's also not that regular. We don't have lung and heart. I think it will take some time to be there.
Right. And that's the struggle, because these patients, once they are maximized on medical therapy and they come to you, like I showed this case, with severe RV failure, they're circling down the drain, and anything you do will tip one balance on one side and cause a problem. I have a question. In systemic vasodilation, the hypotension is mainly due to an underfilled LV. What pressure have you had most success with? In the setting of pulmonary hypertension, if there is systemic dilation and that's the main reason, and only reason, I use vasopressin quite a bit, but I want to make sure that the volume is optimized, and that's tricky, as I said earlier. If there is a reason for systemic vasodilation, for example, let's say you are giving too much of prostacyclin, 80, 90 nanograms per kg per minute of prostacyclins will cause systemic vasodilation. So you don't want to overdose prostacyclins. It can cause a high cardiac output and low SVR state. If you have sepsis or some kind of infection, you want to treat that first. But my go-to drug has been, if you are normotensive, dobutamine or milrinone, and if you are hypotensive, norepinephrine. And I tend to sprinkle vasopressin in early. So you have vasopressin in Nepal, you have norepinephrine in Nepal. So I think those two, and you have dobutamine and dopamine. So I think these are the common drugs that we use here as well.
Parasai, how effective is milrinone in augmenting RV contractility?
It does help, in my view. It does help. The main issue with Saurabh, right? This is Saurabh. The main issue with milrinone is that it'll cause vasodilation systemically and drop your systemic vascular resistance. Now, if the increase in cardiac output due to contractility, kind of balances off the drop in systemic vascular resistance and drop in blood pressure, doesn't occur that much because you're increasing cardiac output. But it's a tenuous balance, and it depends upon how the patient responds. There's some literature on inhaled milrinone augmenting RV function and not decreasing as much systemic vascular resistance, but I've not used it as much, so I don't know personally. But IV milrinone I use quite often. I don't know if any of you have any different experiences, Sambhu or anybody else.
No, I haven't had any experience with inhaled milrinone. We do use, we don't use as much of inotropes. Again, I don't do pH primarily, but certainly there's a role for them in some situations. But as far as the inhaled milrinone, no, we don't have any experience.
Cool. Are there any more chat questions?
Raju, and I think what I see these days is because the sepsis is still a 30 ml per kilo bolus, right?
Right.
And everybody just fit in the same shoes. So the people who have a pulmonary hypertension in the background, they come and they get a 2 liter of fluid bolus.
Yeah.
And patient is septic shock, and we got a more bolus, and they give more bolus. By the time they hit to the the critical care call, they already got like 3-4 liter in the ED.
Yeah.
I think that may be the point to consider when we resuscitate these people. No matter whether what kind of pulmonary hypertension, I think we need to be cognizant to give a small aliquot of the bolus and maybe use the vasopressor earlier. I think for the we have a critical care fellow from Nepal in this talk, so I think if there is somebody with background pulmonary hypertension or you are suspicious, that time you need to be really careful about how you give the bolus. What do you think?
Yeah, no, I couldn't agree with you more. We talked about the reverse Bornheim effect that happens when the septum is already pushing towards the left ventricle. I mean, if there is a clear indication, somebody coming in with lactic acid of 7, 8, you have lower extremity cellulitis, you got urosepsis raging, you need to give fluids and you have to treat that. But in most of the cases, patients, I'll say, that come with this presentation, you have to diurese them more than give fluids in the bulk of the patients.
I think that's an excellent point, Raju. I look back at my fellowship, say, for example, and, I feel like I've at least killed a couple people just by giving them tons of fluid when they now I look back and they actually had pH. So I think in this day and age of like ultrasound, like POCUS, I think all critical care physicians should be able to look at the, do a POCUS and have a look at the RV when people are not really responding to fluid, and make sure they don't have, bad RV dysfunction. I think that's an important point.
And these days, what I changed in my practice is, my personal, Earlier, I used to just more focus on the norepinephrine kind of thing, but use the focus, and if there's a right ventricle looks a little bit big or questionable, you don't have a data, you don't have a shown anything. I kind of put the dovitamin earlier or milrinone, and consider is it a more right ventricle, earlier. Otherwise, oh, this is just the vasopressor, and I tend to use more inotropes these days more frequent than before, and use the non-invasive cardiac output monitor.
Yeah. Good points.
Orgo Pores Dai, I think those people who have pulmonary artery hypertension and they are in a vasodilator like ERA, PDF5, and they come in a shock stage.
Yeah.
In ICU, right? What do you suggest? They are in a fail, the pH exacerbation. Do you recommend them when they're failing, or just use a nitric oxide and inotropes, or holding the oral agent? And कसरी त्यसमा चाहिँ
I've done all combination of all of them. Sometimes I've had to continue. Sometimes I've been able to not continue because they can't swallow or they don't have an NG, and you can't crush these tablets through an NG. Sometimes I stop them and start prostacyclins and inotropes and vasodilators and dovitamin and vasopressors. So it's a hit and miss. I don't think there's one way to deal with these patients. If they can't take oral, you give them intravenous. If you can give them intravenous, if you have the setup for prostacyclin therapy. Most of the time, because RV failure, gut absorption is poor, these oral medications are not being absorbed as well. So I tend to, if I can, switch them to parenteral. But again, the problem with doing that is that now you're committing yourself to a therapy and the patient to a therapy that they may not have the capability or the willing to handle it at home. So you're committing them to a very expensive therapy that requires a lot of support at home in terms of medications for the patient. So these therapies are not to be taken lightly. So I tend to balance all of that, the social costs, the medical costs, and the physiological costs to the patient before we kind of jump into it. But many times I continue those therapies while they're admitted, even if they have hypotension, and try to treat the hypotension with other medications.
Chatमा के question छ कि? Okay. Kamal said great talk and discussion. Thank you, Kamal.
So for us, a quick question again, not pertaining to ICU, to our outpatient setting. Now we have all like oral agents for pulmonary hypertension, and lots of us working in regional hospitals, we tend to start oral agents, and then if needed, we try to, like, if we need some support, we try to send them to tertiary center, pulmonary hypertension center, so that if there is any need of PICC line and IV drips, we do that. But are you leaning more towards oral these days as an outpatient, or do you still stick with, depending on how bad their RV dysfunction is, do you still continue with Velitri or Flolan or one of those drips remotely?
Yeah, I mean, if they are less severe and their risk scores are low, and then oral therapy is preferred. But if you are reassessing them, let's say in 3 to 6 months, and they're on oral therapy, mono or dual therapy, and their risk score is not getting better, now there is enough evidence to kind of track, reveal, and other risk scores. And if that is an intermediate or high risk score, then you need to supplement therapy either with oral prostacyclin or parenteral. So I pay a lot of attention, and I calculate these risk scores every time they come and see me in outpatient and track them along. Now we have EMRs that can calculate that for us in the medical records and Epic. So I tend to do that and use that as a basis.
Another quick question: do you do your right heart cath yourself, or does the cardiology service do it for you?
I do it myself. Yeah. and I did myself, and I've got an interest in kind of doing right heart cath with exercise. I'm trying to develop this program to see, the exercise portion. And I love the physiology, so I'm trying to build that program up. We'll see what happens the next couple of years.
So when I started practice here, I was trying to do my own right heart cath, but the cardiology service owns the cath lab, and most of unless we are in ICU setting, most of we have to rely on them, and sometimes I don't tend to trust their numbers as much when they give me some of the cardiologists. So we have to find one that we trust,
Right, and that's always a struggle most people have. Luckily, in my institution, I was able to find a way into the cath lab, get privileges, get fluoroscopy license, all that stuff, and I do all my pulmonary and critical care fellows tend to shadow me to the cath lab and get experiences that way, because not many people put PA cats in now, right? And in ICU or otherwise, and so fellows are not getting as much experience with the PA catheter, which is sad.
Yeah.
All right, guys, thank you for the opportunity, Raju and Naveen. This was amazing. I really thank you so much, and hopefully the folks in Nepal enjoyed it too.
Yeah, thank you, Paras. I think again this was a great topic. I think everyone was looking forward to it. Everyone has enjoyed it. I think if none of us has questions, we'll end this. I'll try to have it online if I can in the next few days.
Good.
So, yeah.
Excellent.
Thank you, everyone.
Namaskar, Sabalai, namaskar.
Thank you.
Thank you. I'll end the meeting. Okay. Thank you.
Bye-bye.
Thank you.